Thank you, Sammy. After sitting in front of a computer all day, that stretch was exactly what I needed. Our last presentation will be on the topic of hashtag Stop Medical Distancing. We launched a hashtag Stop Medical Distancing pledge to advocate the general public schedule and attend their routine cancer screenings. Over 22 million people have either delayed or canceled their cancer screenings, resulting in over 88,000 delayed or missed cancer diagnoses. We need to stop the spread, not screenings. We need to use our collective voices to educate others on the need to continue their medical appointments. We have linked the pledge in the About tab on the right-hand side to encourage each of you to sign it. I'm very excited to introduce Dr. Yepes, who will be speaking on this topic and tell us the importance of how mammograms, colonoscopies, and pap smears have on early diagnosis and treatment outcomes. Dr. Yepes is an associate professor of clinical radiology at the University of Miami Miller School of Medicine. She has worked at the University of Miami Miller School of Medicine for the past 19 years and has served as the Division Director of Breast Imaging and the Director of Breast Imaging Services at the Sylvester Comprehensive Cancer Center since 2013. She has also served as a Fellowship Director, Director of Breast MRI, and Co-Chair of the Radiology Research Committee. She is passionate about patient care and minimally invasive techniques for breast biopsy and treatment and innovative imaging techniques for high-risk patients.
So good afternoon, everyone. What a pleasure to be here and spend this afternoon with you again. It's an honor to celebrate your journeys, your enthusiasm for life, and your desire to learn. Today, I'd like to discuss the importance of medical screening in the era of COVID. If I had to choose an important word for the year 2020, it would definitely have to be unprecedented. What we faced this year is truly like nothing we've ever faced in our lifetimes. COVID-19 forced us to take a good hard look at everything, as you very well know. And today I'm going to focus on what it's done in terms of medical screening. For the first time in my lifetime, as physicians, we've had to make some very difficult choices, including regarding screening. We were forced to weigh the risk of contracting COVID, which we didn't know much about, against the risk of waiting 2 to 3 months to diagnose a small cancer in patients who had no symptoms. And although extremely difficult and concerning to all of us, the answer, of course, was that we needed to wait a few months to get a better grasp on COVID before we could go back to lives as usual. The effect of this was enormous. In a study that we performed at University of Miami in South Florida imaging centers, our rates of screening mammography went down by 94% during the months from March through May. And this mirrored exactly what was happening throughout most large cities in the country and the world. Fast forward, it's now October. About 6 months have passed since we first heard that our lives, as we knew them, had to change. What have we learned during this time? Well, first, we have a better understanding of how the disease spreads. We better understand how to minimize the transmission of the disease, both socially and within our health systems. We've implemented extensive COVID screening policies so that we minimize the risk of having a patient who has COVID come into our hospital unless they're actually seeking care for that. We've established protocols to minimize the number of people who are within a service at any given time, to minimize your risk of encountering many people in the office. We've provided protective equipment to our staff and physicians to protect our patients and also to protect the staff and the physicians. And we've also implemented numerous protocols, including careful disinfection of our facilities and our equipment to keep our patients safe. And last, but certainly not least, we know that we're going to be dealing with COVID for a while. And because of that, our lives simply have to go on. With that in mind, we have to reevaluate that question we asked a couple of months ago, back in March. And that's, can we safely tell our patients to stop screening until we've dealt with COVID? And the answer to that is a resounding no. As difficult as it may seem, we now have to get back on our feet and resume all the things we knew to be true before unprecedented COVID, including resuming screening for all those cancers that we know are common and that have high rates of mortality and that benefit from early detection. As a breast-dedicated radiologist, my focus today will be specifically on breast cancer screening. We'll very briefly address colon and cervical cancer as well. So, breast cancer screening. What happens when we don't screen? Well, we can only find cancers that the patient herself can find. And how does she find them? Either because she has a lump or because she notices changes in her skin or her nipple. And unfortunately, for the most part, when it comes to that, it's because it's a large tumor. Before the era of screening, the average size of cancers that were diagnosed in the breast was about 3 centimeters, which is almost 1.5 inches. Most of these cancers were aggressive. More than 40% had already spread by the time of diagnosis, and we were treating advanced late-stage tumors. After the introduction of universal screening, we are diagnosing small, clinically silent, meaning tumors that the patient cannot feel or see. And the reason for this is that we want to diagnose them when they're small. Approximately 30% of the cancers that we diagnose are what are considered in situ cancers, and some even consider precancerous lesions. Approximately 50% of the invasive cancers that we find are very small, less than 15 millimeters, which is much less than 1 inch. Only 20% of these will be aggressive, and only 15% of these, 5 to 15%, will have spread to the lymph nodes. Again, the goal of breast cancer screening and of most screenings in medicine are to diagnose precancerous tumors or very small tumors before they become clinically evident, because in this way we can improve mortality and we have better treatment options. So, you know, there's a lot of controversy and there are many guidelines for screening, for breast cancer screening, but I'm going to go over the ones that are endorsed by the American College of Radiology, which we believe are the ones that save the most lives based on evidence. So what do the guidelines of the American College of Radiology say? They're actually the simplest ones. They simply say patients who are at average risk of having breast cancer should begin annual screening starting at age 40. And what's the evidence for this? So there are multiple randomized controlled trials, which you know are the gold standard for proving that a medical intervention works, in which one group of patients are assigned to that intervention, in this case screening, and another group are not. And then they're followed for many years to determine whether that intervention, in this case screening, actually impacted mortality. And what have these studies shown? That screening mammography reduces mortality by 16 to 20%. And this was despite the fact that these studies actually had a lot of flaws. Again, they were done in the 1990s. Why don't we repeat them? Well, because we know that screening does impact mortality, so it would simply be unethical to do that at this time. But we do have many studies that look at large populations where before screening was introduced universally, they could identify those patients that were presenting to screening on their own versus those who didn't. And they've been followed for as many as 30 years. These studies have taken place in countries like Canada and Sweden, and all of these studies unanimously show that screening definitely benefits mortality by as much as 40 to 50%, much more than what the randomized control trial showed, and starting as early as age 40. So there's still some controversy regarding whether we should be screening patients from the ages of 40 to 50, and why is that? Well, breast cancer is less common during this time, but the facts also show that 12% of all breast cancers occur in this population. 17% of all breast cancer deaths occur in the 40 to 50s. These cancers tend to be more aggressive and they grow more rapidly. And therefore, we advocate for beginning breast cancer screening starting at age 40 and on a yearly basis because, again, these cancers tend to grow faster. Bottom line, screening starting at age 40 and yearly increases years of life and quality of life after the diagnosis of cancer. And not only that, it allows for less aggressive treatments. So that's what we recommend for patients who are at average risk of breast cancer. What about those that are at a higher than average risk for breast cancer? Who are these patients? Well, anyone who has a first-degree relative who is diagnosed with breast cancer under the age of 50 should begin screening at least 10 years before that diagnosis. So for example, if your mom was diagnosed when she was 45, you should begin screening at 35. Patients who have genetic mutations that we know predispose to breast cancer, such as BRCA1 and 2, PALB2, CHEK2, and several others that we've identified over the years, should also begin early screening as early as age 25 and no later than age 30. Patients who have chest radiation due to diseases such as lymphoma prior to the age of 30 are also at a higher risk of having breast cancer. And because of that, they also need to begin screening at an earlier age. The recommendation is 8 to 10 years after having completed their treatment or at age 25. Now, there are two other groups of patients that even if they don't have a genetic mutation or strong family history are considered to be at higher risk. And these are the Ashkenazi Jewish women and African American women because statistically they have a higher risk of having breast cancer and they tend to be aggressive cancers. So the American College of Radiology is recommending that these patients present for genetic counseling as early as age 30 to determine whether they have a higher than average lifetime risk of having breast cancer and to determine whether they should begin earlier screening as well. So, is mammography enough? Is that all we should do? So while mammography is the gold standard for screening, some patients who are at very high risk or who have dense breast tissue, and as you know, having dense breast tissue means that your mammogram may be slightly more limited to evaluate breast cancer. So patients who are at very high risk, such as those who have those genetic mutations, or sometimes even many family members, even though they have not been found to have a genetic mutation, will benefit from having annual MRI in addition to their mammograms. And what we recommend is staggering them. So for example, if you usually get your mammograms in January, you should have your MRIs in June or July. And that way you'll be doing one or the other every 6 months. And they should begin as early as age 25, no later than age 30, depending upon that family history. Patients who are not at such a high risk as those with genetic mutations and who have dense tissue will benefit from having ultrasound in addition to their mammograms, not instead of, we still need to do the mammograms, but in addition to their mammograms, also on a yearly basis. Another question, are all mammograms the same? So while digital mammograms are excellent, tomosynthesis imaging or 3D mammography is better. Especially for those patients who have dense breast tissue, we strongly recommend that they have tomosynthesis or 3D mammography. And then there's a newer kind of mammogram that has been introduced relatively recently, and it's contrast-enhanced digital mammography. This is a mammogram with contrast, a different kind of contrast than the one that we use for MRI. And this may be good for patients who have an intermediate risk for breast cancer, such as those patients who don't have a mutation but have a personal history of breast cancer. And again, this is something that you may want to discuss with your physician or your radiologist next time you go for your mammogram. It's also a good thing to consider for those patients who cannot tolerate MRI because of claustrophobia or because of allergy to the gadolinium, which is the contrast that's used for MRI. So very, very basically, I just want to mention that you should not forget screening for other things such as colon cancer. And in general, this is something, the recommendation is to begin at approximately age 45 to 50. And this is something you should discuss with your primary care physician because you may have other risk factors that require starting earlier. And of course, cervical cancer. So the current recommendation is that all women should begin screening for cervical cancer at age 25. This is also you should discuss with your primary care physician as there may be some nuances that need to be addressed with your physician. So to conclude, as healthcare providers and healthcare institutions, our greatest goal at this time is to keep you safe. We can now offer you a safe environment and conditions so that you can resume your evidence-based screening interventions for those cancers that are common and that can be definitely influenced by early detection. And amongst those, of course, breast, colon, and cervical cancer. So please do not put off your routine screening practices as recommended by the guidelines that we've reviewed. Remember, we have to keep moving forward, and our goal is to keep you safe and healthy. Thank you very much for your attention, and have a wonderful afternoon.
Thank you so much, Dr. Yepes. We can't stress enough the importance of scheduling your screenings. Please help us in spreading the word by sharing and taking the #StopMedicalDistancing pledge. In an effort to create a clearer communication strategy, our experts provided key takeaways on managing stress and anxiety, the importance of advocacy, balancing your body with the correct diet, and ways to keep moving. We hope that you enjoyed today's conference, and we hope we can see you live in person next year. Thank you and have a great day.